Okay, welcome everybody. Welcome to the All Ireland ITP Support Association virtual patient meeting. It's good to see you all and some old faces there as well, I can see. So welcome. As always, as you just heard, this meeting is being recorded and I aim to get it up on our YouTube channel sometime tomorrow because they are very popular and we're now actually getting loads and loads of subscribers to the YouTube channel. And so fingers crossed that it continues. A few things really to talk about today. One, we've had lots of useful social media coverage in the last month. One of them was covering common symptoms that ITP patients have. And it would be good to actually get the take from all those on the call today about, what symptoms they've had, because it is very, very different for lots of people. Some people have lots of symptoms, others don't have many symptoms. But also there was an interesting one 2 days ago. We just put feelers out there with the image saying, ITP saved my life. And you wouldn't believe the number of posts we've had. Yes, saying it did because I had ITP and I started bleeding. They tested for this and they found that. So it is really good. But we've got our resident All Ireland ITP Medical Advisor here today as well, Dr. Gerard Crotty. Welcome, Gerard.
Hello.
And we've also got one of the board members who assists me on all of these meetings, patient mentor, Mrs. Rhonda Anderson. Welcome, Rhonda.
Good evening, everybody. Thank you.
Okay, so who would like to go first? Someone must have a question or something, or just an anecdote about their ITP story. Because another thing that we're looking at doing is trying to do some podcasts, and we want to talk to people about their ITP story. No video involved, just a straight, audio podcast. And one of the new trustees is going to be involved with that with me. But anyone would like that, and I can see Sue shaking her head there, so I'm sure Sue would like to have a go at that in the future. But if you would, just drop me a line. That would be really good. So who would like to go for, basically who has the first question that they would like to raise? Anyone? No? So
But I can mention just
one
thing you sparked me there. There's in terms of people, ITP saved my life or whatever. That's, I suppose, anecdotal, but there is a general rule that if someone has bleeding from an unusual site, a site you wouldn't normally have bleeding from, that even if you find, an underlying cause, you might, so if you have bleeding from your bowel, even though you might have a bleeding disorder such as ITP that might at least partially explain it, you probably also need the colonoscopy to exclude there actually being a lesion there that just was the first place to bleed when your platelets started going down. So it's a general kind of rule of thumb. I mean, colonoscopy or a gastroscopy, our tests they're often done even as screening tests in some countries. So if you have bleeding, and you're of an age group, middle-aged or so the in particular where the risk of a malignancy is there, then go and have that investigation as well. So don't assume that all bleeding is due to low platelets or some cause that's found. Think could there be more than one thing contributing to it?
Yeah. There was one lady on the social media that said she had a blood discharge from her left nipple. So she went to the doctors and they actually found breast cancer. And she wouldn't have gone to the doctors if it wasn't for the discharge. And another person, a chap, said he was having his ITP being monitored weekly, like a regular blood test, and they picked up multiple myeloma. So there are, I know you can't say it's a benefit, but having all the blood tests, can be a godsend in some cases. So yeah.
Gerard, do you have a bowel screening in Southern Ireland?
We do have bowel screen. I'll have to, I think it's from age 50. I'll have to, there might be talk about changing the age. But anyway, once people who have a number with the health service, I think they're probably all on the register, and you get a letter inviting you to participate when you reach the age, and you can check online if you're on it. It's called bowel screen, and you just take the sample and put it in the envelope, send it back, free post, and you get your report. And of course, that's your first step in a screen. If it's positive, it doesn't mean you have cancer, but it means that you'll be selected to have a colonoscopy as a screening test. Yeah.
I think this might be an opportune moment to remind people that if they do get these, poo in the post, they call it.
Yeah.
If you get one of these tests, then please do take it. A friend of mine had a husband who used to throw them in the bin. And she went mad one day at him and said, you've got to do the test. And of course, you can guess what happened. He did the test and he had bowel cancer.
Yeah.
And he had it quite badly, actually. He's had a lot of treatment, operation and treatment and so on. So it's much better to get these things early. And bowel cancer is one that is very treatable if it's diagnosed early.
My father had the same test and they diagnosed bowel cancer, and they ended up taking part of his colon out, but it was fine.
Getting back to ITP, there wouldn't be a strong association between ITP and cancer really at all, but in a small number of cases, autoimmune phenomena can be due to a malignancy. So there should be a kind of a general, certainly any age appropriate screening that should already have been done, should be done, just while we're at it, talking about preventative medicine, I was just off one of the education webinars from the Royal College of Physicians here, and they were talking about vaccinations and autoimmunity. And there are, after vaccinations such as influenza, there is a low incidence of a new presentation of ITP, but actually in terms of low platelets and autoimmune disease in general, the incidence of that happening is much higher if you actually don't get the vaccine and actually get influenza or get COVID itself, the disease, instead of getting the vaccine. So there are some slight risks with vaccines of stimulating autoimmunity, but certainly for common diseases like that, they're vastly outweighed by the higher risk of the similar autoimmune complications from getting the actual virus.
Okay. Thank you for that, Gerard. Just a quick question, Gerard. In the UK, NICE have just approved generic L-Trombopag for use. What's the position in Ireland? I'm
actually not quite sure. When I was last in the hospital, as I was just saying before we the rest of you joined us, I've retired from my full-time clinical post. And I am doing some part-time clinical when they need me, but I am working on a laboratory information system as a half-time post. So it's possible it has changed since I was there a few months ago, but it hadn't reared its head when I was there, so that was,
it's changed in the UK or England and Wales anyway, and Scotland as well, from the 1st of October. But the savings to the NHS in particular are colossal. It's gone down from 40,000 a year to about the cost per patient to 4. So it's a huge saving, when you add up all the patients who are on it. So amazing.
So that's not the same for Avatrombopag then?
No. Avatrombopag is still on patent. L-Trombopag, how the patent system works in UK and Europe, they're on patent for 10 years. So basically, when a pharma company produces a new compound that gets approved and could be used, that they can basically charge a price that will recoup the investment plus a bit of profit, in some cases lots of profit, for a period of 10 years. After 10 years, they then have to make that compound available, or the guidelines to producing it available to other providers who can then sell it cheaper.
Right.
In America, it's 7 years, but in Europe it's 10. So yeah.
Merv, can I ask a question?
Yeah.
Go on, Sue. Fire away.
Well, I'm not yet on L-Trombopag because platelet count sort of smoothed out a bit lately, but the other option was Avatrombopag. So would you have to have L-Trombopag first, and then if it wasn't used, didn't suited? No.
I'm not sure, not in Ireland anyway. In the UK, or in England and Wales, I think because they brought in as a national program the generic L-Trombopag, and it is so much cheaper, there's a strong pressure to use L-Trombopag instead of Avatrombopag.
Yeah.
I don't know if I don't know what sort of a form the doctor has to fill in and give a reason why L-Trombopag is not so suitable. But there's probably a couple of extra hoops to go through before
we did I did a joint statement with Dr. Quinton Hill, who you know, Gerard, from the ITP Forum and the ITP Support Association, about the use of generic L-Trombopag. And basically, because it's a second line, once a patient gets onto the second line, that will be offered first. But as we know, not all TPOs work with all patients. So it will be a case that patients will have to be moved to other TPOs, which is L-Trombopag's one, Avatrombopag's another, and there are several others. Yeah. So
is L-Trombopag the one that is something to do with dairy? You've got to be careful how you take it.
L-Trombopag,
yeah.
Okay.
So it's not working. If you don't follow those guidelines, then with the diet, it will reduce the
the calcium effect.
So it mightn't work. So that can be one reason why it's not working, and can be worth examining that. It's
which is why lots of people, to be perfectly honest, don't actually get on with it because of the dietary restrictions. Which is why, and in particular, youngsters would prefer an injection or a tablet form, but with no dietary restrictions. Older people are more sort of robust with that, but so
interesting.
I had one patient who so much liked his dairy products that he decided the best schedule for him was to set an alarm for 4 a.m. and wake up and take his tablet and go back to sleep again. Not really what I would recommend.
No, it's not. No. But and I know talking to I was talking with Professor Nikki Cooper yesterday in London, and there are a number of clinical trials actually underway now as well in the UK and in Ireland, I believe, as well, looking at the list. And we're just trying to collate a full list at the moment, and we will publish that when it's done. But there's some interesting stuff going on. So
Thank you.
Could I ask a question?
Yeah, Karen, go on.
I'm relatively new to this. I've had this since March, and it's been very much up and down. And I just wondered, is there ITP specialist hubs anywhere, or
there is? Whereabouts are you based, Karen?
Bedfordshire.
Bedfordshire, yes, there is. Yeah. You're just down the road from me, then.
I am. Yes.
I should call in, but yes, there are. If you go on our website, there is a link that shows all the ITP specialist centres. Which hospital are you under at the moment?
Bedford
Hospital itself.
Yes.
Which you've got a very, very poor rating at the moment, isn't it?
I don't know.
Yes, it has generally. Yeah.
Oh, right. Well, it's a very long waiting time in A&E, I can tell you that.
Yeah, it's the same everywhere. But if you're not happy with it, you can ask your GP to refer you to one of the ITP specialist centres.
Because I'm new, I just don't know really.
Yeah.
It has been very up and down.
If you
you know.
email me afterwards, Karen, I'll send you the link for it. Yeah.
Okay.
Right. Okay.
Yes.
So, yeah. Great.
Yes.
Stuff. Yeah.
So did you want to go into what symptoms we have, or
Yeah,
what?
please. Yeah. So what's your symptoms?
Mainly mine is, well, I don't really notice it until I have the bruising, basically, the low platelets, that is, and it's a gradual reduction in energy, and a great thing, like a lot of people say, is fatigue, and that is enormous. And having come from being very active to suddenly being able to hardly do anything has been very hard, really. And I just feel that there's no way out of it. It feels like that anyway.
Okay.
And so, you know, I just
what's your current
1 minute I
platelet
feel
count?
I'm getting better, and you know, I get the tablets and it's better, and that's fine. And then suddenly, no, it's not
Dips
fine.
again. Yeah,
And I think,
Do
what am I doing wrong? You know,
do you know what your current platelet count is?
It's 111 at the minute. It was
111,
below
okay.
4 last week, so
Okay.
All right.
Okay.
it's
Gerard?
very up and down like that. And it seems to be every month I'm in there, or you know, something's happening. Anyway, so.
Very common situation, Gerard.
Yeah, well, I mean, most people do actually find some dose of one or other of often the second line agents. I mean, because the first line agents, just for anyone who's not really familiar with the whole situation, I mean, some people with ITP don't need treatment if it's just mild without bleeding. Some people might. There are a couple of forms of ITP. There's acute ITP, which might go away in less than 6 months. And the first line treatments, certainly in Ireland, it's steroids or intravenous immunoglobulin are the two first line treatments that are used in Ireland. Some places use anti-D as well. I don't know if it's used much nowadays in the UK. It was never really available in Ireland for treatment of ITP. And then most people in adults, the chronic form that goes on for typically longer than a year, it could be many years, but can fluctuate. It can need treatment at times and not at other times. But most patients with that, if they do need treatment, may well need one of the second line agents. And the TPORAs, which would include eltrombopag, avatrombopag, and romiplastim, which is the last one being an injection. They're the most common second line agents, but there are others. So, you know, in terms of what Karen, I think is your name, what your treatment, you know, if you're on a second line agent and
I'm on avatrombopag, yes.
Yeah, and are you long on it?
Well, I started this journey in March, and I don't think I was on it straight away. I had prednisolone initially, and then when that didn't work, I think I started on the avatrombopag. The brain fog is the other thing; you can't remember half the things.
Yeah.
And I'm just coming out of having been very low, so I'm not, you know, not quite with it really. But anyway, yeah. So there's been avatrombopag recently, mainly, and prednisolone, yeah.
Right, so you're still needing steroids.
Well, I have boosts. I have 5-day boosts,
right.
And at the moment, when it's been very low, like below 4, which is not good, and then it seems to kick in, and then the avatrombopag, I'm now having 40-20, 40-20, and then 20-20. So they're trying to get it. Well, I think they're trying to get the medication right, really, and trying to get the level.
Yeah, I mean, you know, it can take time, and
obviously, yeah.
There are some people where it does remain quite variable with up and down quite a lot. I think they are a minority of people where it's up and down enough to cause actual clinical bleeding or admissions or symptoms. Most people do find some combination of treatments that will have it stable, but then there's a minority where it's actually very difficult to stabilize. So
Yeah.
I mean, and the TPORAs are generally those, that's the right group of drugs to be trying to stabilize on. But in some cases, other treatments, such as rituximab is a second line drug that can also be used. There are also immunosuppressant drugs, and there's also a drug called fostamatinib that's now approved, I think reimbursed in the UK.
It is, yeah.
In Ireland, it's not reimbursed, but I've just heard recently some people are able to get it. You can get it in Ireland. It is approved. It's the EMA and HPRA approved, but the reimbursement, the payment for it hasn't come through in Ireland. But you can get it funded by your hospital in Ireland if you can make the case. And often these patients are requiring frequent doses of intravenous immunoglobulin, which is actually quite expensive. So if your doctor can make the case, actually, although it costs money,
I did have a bit of that.
Yeah, it's cheaper, but your doctor could, and certainly in Ireland, and I don't know if it applies to any of the people online here. Your doctor could make the case that it is actually cheaper to the hospital than the intravenous immunoglobulin is. But those sort of things, who pays for things and so on.
Yes.
Immunoglobulin is managed differently in the UK versus Ireland. There's an immunoglobulin program in the UK, whereas in Ireland it's really up to the individual hospital level. So questions about is this available and does the health service pay for it are going to be different in different countries.
They will. Yeah.
And even in the UK, they have at times been different between north of the border in Scotland and in England and Wales.
Well, there was a case this last fortnight because there's a tourist coming over from America. We always try and help them out. I think you may have helped them out last year or the year before when they went to Ireland. Gerard.
Oh yeah, right, yeah. Maybe get advice about what the nearest centre was. Yeah,
they've since been to the England as well. We sorted that out, but they're now going to Scotland next month, and it's entirely different again. Right, and trying to do it, I finally tracked down someone, a consultant, who would be prepared to actually look after them. Again, it's the injection, because for those of you who don't know, in America, romiplostin, as you know, it's injected, but patients in the USA are not allowed to self-inject. It has to be done in clinic. But over here, patients can self-inject. So the problem is, when they come over here, that firstly, they have to get their own supply over here. They're not allowed to bring it with them. And then they have to find someone to actually administer the injection for them. So, we've done it in Ireland, we've done it in England, and now we're finally going to do it eventually after, going around the houses for about a fortnight in Scotland. But as Gerard said, it's entirely different in each of the home nations. So, yeah, crazy.
Yeah, I think, Karen, it's obviously very distressing to be going through what you're going through. And I think that one of the things that could be helpful to you would be to find some strategies to address that. So have you managed to do any of that with yourself or your doctor or anybody?
Do you mean daily living?
Yeah, so, addressing the stress and, the distress that you're feeling over the whole thing. And you said that you'd been feeling a bit low and that kind of thing, which, comes with a long-term condition that you're trying to get some treatment for and perhaps not working as well as you'd like. So just wondering if you've had any ideas about how to address some of that kind of stress and so on.
Well, I mean, I've always been I've been doing yoga and things like that. If that's what you mean, I'm not sure. I think that's what you mean. But I haven't had the energy actually to do it. I have actually gone back today, and I'm now going from ground yoga to chair yoga, if you see what I mean.
Yeah.
So that sort of thing. And I did go back because I was a wild swimmer as well. And I haven't, that's my sort of way I deal with stress basically is to do those things, and I haven't been able to do them since I've had this. Although latterly I've managed to get back. I did actually get back to wild swimming last week. I had a really good day, and then at the end of the week I was 4, and it was like really rubbish. It was like, what did I do? Should I have gone wild swimming?
Yeah. I think one of the other things that we would say is, you know, the platelet count is a number.
Yes.
And, you know, you have to see how you are feeling with your platelet count, either high or low, and what your symptoms are and how you're dealing with them.
Well, yes, it's generally pretty rubbish when it's low, because you suddenly, you're so tired. You're just so tired.
Yeah, yeah.
And you can't function, really, not very well.
People do have all sorts of strategies for that. So it might be helpful to look up the spoon theory, which is spoons of energy. Do you know about that one?
No, not heard of that one. No.
Okay. And then the other one is small action plans to do things for, say, 5, 10 or 15 minutes, according to how much energy you think you've got. So in an hour, you might do something for 5 minutes and then rest or whatever. And I think that in daily life, it's really important to sort of build in these things that are going to make you feel as though you've got a sense of achievement in doing things, and that you're parceling out your energy so that you're not thinking, well, in the past I could do, you know, like 8 hours straight and not sit down. And now you've got to sort of think about it. Yeah,
I have got to that conclusion. I try to put blinkers on.
Yeah.
So I just do that little bit. Don't look at anything else. Just do that bit. Sit, rest, then, you know, do the next thing.
Yeah.
So I have got to that point where, because you just have to. I think.
Yeah. You might like to keep a diary or journal of what you're doing, and then so at the end of the day you can look at what you've done and think, well, I did really well today. You know, and then another day you might say, well, I don't feel as though I did anything much today, but I did have a lot of rest and that was what I needed.
Yes, that's a good one. Thank you.
Know, so it's sort of being very kind to yourself. You know, so that you can actually, no, well, none of us are good at that. But you've then got to say, well, you know, I'm going to be kind to myself. I'm going to do something I really enjoy, might be watch a film on television or something. And then, you know, you add that to the things that you did today, even though you were resting while you were doing it.
Yes.
Because I know it's really terrible, because we all feel very driven to do things, and I mean, I'm one of the worst people about that, so I really understand. And you know, we're all sort of very focused on producing things or doing things, and when we have been able to do that and then can't, it is a tremendous blow to the ego.
Yes, and it's putting on all this flipping weight as well. It's just like, oh no, now I'm putting on weight because I'm not doing as much as I did.
Yeah,
So
well, you might be able to work that out by having a very short walk. So I mean, in my place, I can walk out the gate and walk up the road onto the green, and then walk back again.
Yes, I've done that.
My walks are getting very short. Exercise, yeah. I mean, it's just sort of thinking in the most basic terms of how you can organise your life so that you don't feel every day that you've wasted your whole day.
No, that's true. Because I have 2 dogs, you know, I used to go for 2-hour walks and do about 22,000 steps, and now I'm doing like 5 or not even that, probably.
Yeah.
But anyway.
And I think the other thing is to get as much help as you can from, I don't know if you live alone or whatever, but family members, and also your GP and your medical team. Definitely.
Definitely.
Yes.
I don't know if Gerard's got anything to add to that.
Yeah, but I was just going to say that fatigue is a very common symptom in ITP, and it's not that well understood what the mechanism is. And actually, ITP is probably not really just one condition. There are different versions of it depending on what part of the immune system is involved, the antibodies or the T cells, which also is the reason we presume why for some patients one treatment works and for another patient a different treatment works. But the fatigue is definitely now recognized as a symptom. It's not just the stress of having low platelets or being on steroids, which itself is of course a cause of stress and discomfort as well. But it is an actual symptom of ITP. It doesn't always correlate well with the platelet count, so it often does to some degree, but it's not guaranteed that if your platelet count's over 100, you're going to have lots of energy and vice versa, that you're definitely going to feel fatigued when it's very low. That varies again between patients. Some patients have no idea that their platelet count has gone down to below 10. And it's just a surprise sometimes when they turn up in the clinic and have a blood test and they find it's low, whereas other patients can tell you from how they're feeling, what it's likely to be, So it is quite individual, it is varied, but fatigue is a definitely recognized symptom and not straightforward to treat because it does require self-management as well as sometimes the medical treatment as well, because some of the treatments like steroids, for instance, will in the short run bring up your platelet count and bring up your energy, but they have very serious side effects if they're continued in high dose for long periods. Hence, there's a need to, try and get off the steroids if possible, and or down to a very low dose, and get on one of the other treatments that's better tolerated as a long-term treatment.
Okay, Karen. Yeah. Just to point out as well, over the last few months, we held 3 virtual meetings with a clinical psychologist called Dr.
I did see that one.
You've seen them, yeah. All the videos of that are on our YouTube channel. So he described and talked about a number of techniques as well, that can help. But conversely, just going on the fatigue issue, I was at a meeting yesterday and we was talking about the IWISH survey, IWISH 2. We was going through some of the results of that, and conversely, I think it was these figures are just coming from memory now. Either 60 or 70% of people, ITP patients, knew when their platelet level was dropping due to their fatigue level increasing, but conversely, 30% of people still had fatigue when their platelet level was over 100, and no one could put the two together. So very, very interesting.
And it's difficult. I mean, fatigue has other reasons as well.
Yes,
Apart altogether from having a condition like ITP.
No.
We have jobs and relatives, sick relatives, maybe children.
Daily life.
We have care responsibilities which make us fatigued. So one can be tired or excessively tired for there can be maybe a multiplex of contributing factors. So it's hard to tease it out, and it is an individual thing. And what activity you can do again is individual, but definitely there's almost no conditions in medicine except for some very short-term things where actual total rest is beneficial. For most conditions now, if you're not able to do your normal level of activity, do try to do some, as Rhonda was saying, a short burst of walking or whatever it is, try and keep mobile and keep active to the degree that you're able to, while also discussing it with your doctor and perhaps having your treatment adjusted and changed to a different agent. Some doctors, I think every hematologist should at this stage be aware that fatigue is a recognized symptom of ITP. Other doctors may not, because ITP to your GP or to a rheumatologist or whatever is an uncommon disease because they don't see it that often. And they might be unfamiliar with fatigue being a symptom of the disease. So you may sometimes have to fill in for your doctor a little bit on the information, perhaps download some of there's a lot of information on the ITP Sports Association site and in the newsletters and so on.
Yeah,
I do see a question in the
I'm just looking at that now. Yeah.
So that's Sue, I think.
Yeah.
So you're asking about inject. There's only one reason I think why a rheumatologist would say to avoid injections, that they're worried that at the time your platelet count would be very low and that might cause the needle going in through the tissue on the way into the joint might cause bruising or bleeding or even bleeding into the joint, which isn't a very big risk unless your platelets are really very low indeed. But if your ITP responds well to treatment, then there's a workaround for that, and it's to be on the treatment, have it monitored, and have time your platelet count for very shortly before the injection might be due, and then you can reassure your rheumatologist that there is no contraindication. The steroids given into the joint for various painful joint conditions don't lead to a significant systemic dose around the body. Because it's given into a very localized area, for instance, in your shoulder or wherever, when it does work its way out into the circulation, the amount is extremely tiny on the body. So it's not going to contribute to steroid side effects that you would have similar to if you were on oral steroids, prednisolone or dexamethasone in the past.
Thank you.
Okay, thank you for that, Sue. And I know Marvad had a question, but just before we go there, Karen, I've put the link for the ITP centres in the chat. So
right, okay.
You can Marvad, you put your hand up.
Yeah. My question is, when is the right? Sorry, my name is Marvad. I got a daughter with a special needs. She suffers with ITP. My question is, when is the best time to have a flu jab and a COVID jab? Is there any particular time she should have it?
Well, for the flu jab, really from now is, very early. In terms of the best protection against flu, around now, October, November is the best time, or very early November is the best time to get it. You don't want to leave it too late. The flu actually arrives and you get it before you've had the vaccine. And there's some evidence that if you get it very early in September that it might have worn off a little bit towards the end of the flu season. But around that then, if there's a lot of fluctuation in the platelet count, it may have to, it's not contraindicated to get it when the platelet count is low, but a few people will get a minor drop, only rarely anything more than that, perhaps a week afterwards. So if you're concerned about it, causing a further drop in your platelets, you could arrange to have a platelet count 1 week after the vaccine. And so you could, if your platelet count is very variable, you might just discuss with your hematologist what the best timing is. But in general, for most of us, I got mine a couple of weeks ago, and COVID. Again, the guidelines vary by country and year and season and age group and so on. I think, if you're on immunosuppressive therapy for an autoimmune disease, which ITP is, you do fall into an at-risk category. So even if you're in the younger, I know in Ireland they're not routinely recommending COVID boosters for young people without a concomitant condition. But I think ITP requiring treatment with, certainly with anyone requiring treatment with immunosuppressants or steroids or having had a splenectomy, or having had rituximab, would fit into that category of a condition, putting them at increased risk of infection. And of course, people over 60 again are in a higher risk group anyway. Again, the guidelines of who should get a COVID booster vary, and they may be different next year what they are this year. I don't know if they've really settled down to a regular pattern. And COVID doesn't, I mean, it hasn't become fully seasonal like flu is. So there might be a bit more in the winter, but there's also summer waves as well. I think most countries are having more than one wave a year, you know. Obviously, the consequences are not, now that most people are vaccinated in the community, the consequences are not as severe as they were in 2020 or 21. But they're you know, so I think it's again, follow national guidelines really, and but just if you are either older or receiving immunosuppressive or from time to time receiving immunosuppressive therapy, you are in a higher risk group, and if it's optional, then I would opt for getting the COVID vaccine.
Mm-hmm. You don't wait to be called then?
Again, in Ireland, I don't think they're calling people. You go online and book your appointment. I am not. Again, it depends on what the system is where you are. I mean, you can discuss with your pharmacist or with your GP.
Okay.
In the UK, it is if you're 75 or over, or if you have an autoimmune condition, you qualify. Whereas last year it was, I believe was it over 65, Rhonda, or 70 last year? I can't remember what it was.
I don't remember the age limit. I just know that I was okay to have it, so I dropped into the age limit.
Well. Yeah. So I think it was 65 last time.
But it does change, and it differs between different jurisdictions.
It does.
If a patient asks me, and they are here in Ireland, I just go on hse.ie and Google the current recommendations.
It's the kind of thing you can look up if you put it into Google and you put NHS. Look at the NHS site, and it will tell you everything you know. And I must say that all of those things on the NHS sites on Google are really very good. They're very, very clear. Anything you look up comes up very clear, and it gives you good advice, but you don't have to read thousands of words. You know, it's all very bullet pointed, and it is worth looking anything up like that just comes into your mind and you want to check. And also you do sometimes get, if you're on the NHS app, you will be contacted to say, I was contacted to state that I could have my COVID vaccine, and I've had the flu, and also if you are told that you can have RSV, it would be a very good idea to go and have your RSV as well, because that is a respiratory illness, virus, that they're trying to get, you know, under control, because it can be very nasty for people who are vulnerable in any way. And that's also, I believe they're vaccinating pregnant women with that too here. So are they doing that in Ireland, Gerard?
I don't think so, no. No.
Okay, because it has implications for the baby. When babies get this RSV virus, it can be very serious. So that was what Catherine Baggett was saying, that wasn't she last time when we had our Zoom? So any vaccine that you can have, and I'm sure that Gerard will back me up with this, if you are offered any vaccine, it should be fine for you to have it, even though you've got ITP. If you've got a very low platelet count, it might give you a bruise, and you just need to press on that. It might bleed a bit or bruise, but Gerard can tell us about that.
Yeah. What I would also say, Gerard, before you go on there, that the Health Service of Ireland website is also equally as good as the NHS. You know, there's some great information.
Oh, yes. I just meant the ones, the official ones. Yeah,
I understand,
Yeah, but we were, although the HSE.ie seems to be down this afternoon.
Oh, is it?
Hopefully it's
Oh.
only a brief blip. We were just talking. I was trying to get on it earlier, but the RSV. Yeah, I don't think. I mean, there are various treatments in that and I think there's a vaccination for babies. I don't treat children now, so I don't know the details of that. But it's not being routinely offered to adults, in older age groups in Ireland at the moment. The RSV is also seasonal. It tends to hit a bit earlier than flu. Really, anytime from November, mid-November to December is when it tends to hit. So it typically a few weeks before influenza. So something else I was going to say. We do have another question in the chat there from Sue as well.
From Sue again,
about the risk of clotting. Yeah, now we tend to focus mostly on the risk of bleeding, and of course the risk of bleeding is in people who have severe ITP with very low platelets. That is the predominant risk. However, ITP is also recognized as a pro-thrombotic, pro-clotting disorder. Now, for most people, that's a very small statistical increase in risk over the general population. And it doesn't necessarily alter your treatment. If you're having symptoms from low platelets, symptoms from your ITP, it's not a reason not to treat it or anything like that. And it can exist even while the platelets are low. So and it's not all that well understood. There are a few very rare specific autoimmune conditions. The best known one being antiphospholipid syndrome, which can produce symptoms similar to ITP with low platelets, and is a disease, a condition that can lead to clots. So certainly, if you have, it's important when you're seen, and I think most patients with ITP should be seen by their hematologist initially, and that would be considered as an alternative diagnosis. Although if the symptoms and signs are only that of ITP, it is not routinely recommended in most guidelines that the antiphospholipid antibody tests are necessarily always done. Some hematologists will do them, so some will not. But apart from a few, and there's a few other really, really rare specific antibody-related problems that can cause low platelets and clotting. But if you take ITP patients in general, or people with ITP in general, the risk of a thrombosis in a vein, particularly in the vein, not so much with the artery in general, the risk of a venous thrombosis, and that's either a DVT or a pulmonary embolus, depending where the vein is. So DVT is a clot in a peripheral vein, usually in the leg, lower limb, and pulmonary embolus is a clot that it probably originated in a lower limb or in the pelvis, but traveled to the lung, where it caused signs or symptoms and has been diagnosed as a clot in the lung, but one that's a venous clot that has traveled to the lung. So the risk of DVT or PE is a bit higher in patients with ITP. So it does mean that patients with ITP, if they're admitted to hospital for other reasons and their platelet count is above 50 and there's no contraindications, they should be considered for preventative injections to prevent clots if they meet the criteria for prevention. Because one of the most common settings where venous clots occur is in hospital. It may be in hospital for some other reason, for a variety of reasons. It's often the underlying reason that led you to being in hospital is part of what contributes to the clot. But the immobility of being in bed and maybe having had surgery and not moving and so on and having inflammation, those are all contributory. So in certain situations, patients with ITP should have treatment to prevent clots. mainly when they're admitted to hospital.
What about long haul flights then? If you're on a long haul flight,
we don't routinely in somebody
No.
who has a risk factor, be it ITP or other moderate or mild risk factors for clotting. We don't routinely recommend that you get an anticoagulant drug to prevent clots while taking long haul flights. The risk, the absolute risk, is quite low, and all anticoagulant drugs have risk of bleeding.
Yeah,
And,
sure.
you know, speaking of a friend, I know someone who took a blood thinning drug, and then as soon as they got on their flight, someone opened the overhead bin above them and dropped their hard shell suitcase on their head. So no sequelae occurred, but there are risks of taking a blood thinning drug, and the absolute risk of a clot is low, and the period for which you're at risk is low. So we do recommend a number of things for anyone who is at risk of clots, and ITP is one among many possible risk factors, and other risk factors include some things unavoidable. Older age is a risk factor. Having obviously certain serious medical conditions like cancer, bad varicose veins, obesity, immobility. You know, there's a number of risk factors for thrombosis. But people who are at risk, and people who are not at risk actually, if you're on long haul flights, move your legs frequently during the flight. So exercise them in the seat, you know, do your ankle raises and your toe raises, obviously without too much annoying the people beside you on the flight. And when permitted, you know, do take the occasional walk up and down, you know, to when allowed. Although I think nowadays they seem to facilitate the trolley and also the landing process by putting on the seatbelt sign for turbulence at the slightest bump of any sort and leaving it on for the remainder of the flight. But if you're allowed to get up and walk. Also, if you have an additional risk factor, if possible, get a seat with a little bit of space that allows you to do that movement. So even just an aisle seat, which usually doesn't cost any extra, or an exit row seat, or obviously if you want to pay for business class or whatever, that's also an option. But just even the aisle seat, it means you're more likely to get up and have that walk or stretch your legs a bit and move around. Also, remain hydrated. So bring your empty water bottle on and fill it after security, or buy a bottle. You know, because sometimes they're very slow to come around with a drink, and it can actually be quite temperature varies, and it can be dehydrating. So avoid getting dehydrated. And the other thing is flight socks or support stockings. They definitely prevent swelling. Some people get swelling after long haul flights. If you're not moving much, the jury's out on how well they actually prevent DVT. But if you find them comfortable to wear, then certainly nothing wrong with wearing them if you don't have unless you have reduced arterial circulation in your leg.
Right, thank you very much for that advice.
Just on the flying points too as well, and everybody on the call. Within the last couple of weeks, we did a day on our social media Facebook page, asking people with ITP to tell us their top tips when they're doing, you know, sort of going on flights.
Oh, I didn't pick that up. Sorry.
Yeah, top tip. There's about 19 or 20 people replied.
Great. Okay,
so have a look. There's some good ones. There's even a few cabin crew with ITP.
Oh wow!
Give their tips as well, which is interesting. So, you know, bearing in mind, we have heard of pilots in the past who've been diagnosed with ITP, and they're actually barred from flying if it drops down to a certain level. So yeah,
Interesting.
It would appear cabin crew are okay. You know, looking at some of these numbers. So
yeah. Wow.
Yeah.
I suppose they always need two pilots.
Absolutely, yeah.
One commanding and one flying, and they don't want one to be incapacitated by a nosebleed.
Absolutely,
that might be relatively minor.
Yeah,
they want both to be able to stay in the cockpit really at all times. You know.
Top reason.
Yeah.
Right.
Is it true? Sorry.
So, Karen, Rhonda's just put on there. If you email me Right,
Right.
I will put you in contact with Rhonda,
Yes.
okay, and you can have a chat with Rhonda, and hopefully that will help, with your
Mm.
fatigue issues, and just have a
Mm.
chat with someone who's been there. And
Mm.
yeah,
Yeah. Lovely. Thank you.
no problem.
Okay.
No problem.
Yeah. The other thing, I don't know if you said this or not, that the platelets that are produced might be fewer in number, but they tend to be a bit bigger and stickier.
Oh,
And
right.
that is one of the reasons, I think, Gerard will correct me if I'm wrong, that you're also in danger of DVT thrombosis of some sort if when you've got ITP.
I'm interested.
Yeah, theoretically anyway, I don't know that it's been scientifically proven that is definitely a factor. That let's say it's more complex than that. The research into why ITP is a prothrombotic condition yields a lot of different clues, which might all add up to an increased risk in some patients anyway.
Okay.
Yeah. But it's also, I mean, that's also a reason why some, again, bleeding symptoms vary. But compared to having some people and other, there are other causes of low platelets. So, for instance, someone post chemotherapy for cancer can have low platelets, and they tend to bleed more for a given platelet count. Because their platelets tend to be old, small platelets, they're not producing the platelets, whereas patients with ITP generally are producing them. However, it's not always the case that the bleeding is less than you'd expect for the platelet count, because ITP, as I mentioned, some cases of ITP, it is autoimmune, and antibodies to platelets are part of the mechanism, the pathogenesis, as we say, the mechanism of ITP. And in some cases, those antibodies actually do target specific receptors on the platelets that are needed for their clotting function. So some patients with ITP, the platelet function may be a little impaired as well,
Okay.
I hope one day they can find the answer to all of these intriguing
Yeah, well,
questions.
There's loads of research going on.
Yeah.
As with a lot of things with the immune system is incredibly complicated. And I mean, I learned about the immune system as a medical student, and most of what I learned then back in the 1980s is now not true, because it has been found out to be much more complicated than that, and in some cases quite different to what I was taught. So I think it's unlikely to be finding the answer. I think there will be more and more options, and there are new drugs becoming available. And I briefly referred to drugs like fostamatinib, and there's rilzabrutinib, which I don't know has any approval anywhere yet. But there are new drugs which are and new ways of treating the immune conditions. And there's another class of drugs, what are called the FC receptor inhibitors. So there are quite a lot of new avenues for treatment being explored and being studied in trials and in preclinical studies. I don't think any of them is really promising to be the answer, that there's going to be a magic bullet discovered in 5 years' time and that'll be the end of ITP. It's far more likely that it will be incremental, and that for many patients, the drugs we currently have and the treatments we currently have will be the treatments, and for others, it will be the new drugs. But sometimes new drugs are better than the old ones. For instance, for many years, we used immunosuppressant drugs like cyclophosphamide and azathioprine and cyclosporin and mycophenolate, which is still used to probably where you have to use one of those would be the one probably to choose. And they were considered the second-line treatments. But that was because we didn't have any other second-line treatments except splenectomy. But when the new treatments came along, the TPORAs initially were, you have to use it after everything else has failed. But that didn't last very long. It became clear very, very quickly that they were superior to immunosuppressant agents. Immunosuppressant agents only work in about a third of patients, so you have to keep trying different ones to find something that works. Whereas the TPRAs work in probably 2/3 or more, up to 90% of patients. So you, in that case, the new treatment largely replaced the old treatment, but the old treatment, the mycophenolate and the azathioprine still are there, and if everything else has, if a number of other treatments that we've mentioned have failed, they could be considered. But I think the number of people going on those nowadays is quite small because of the other options that we have.
What I would say as well on that, just before we close, and if anyone's got any last questions, is that I know it's not very encouraging for people who have got ITP at the moment, but if you went back 20 years, you are now in a far better place than the people were 20 years ago.
I've had it for 45 years.
Yeah, there's far more options now, as you can say, Sue. There's far more options now out there, to help treat this condition.
Yeah.
Okay. Not all of them work, but eventually, hopefully, we can find one that does eventually. Yeah.
Yeah.
Bad, you had your hand up just very quickly.
Yeah, just a quick question. My daughter was prescribed, her ITP count was low, so she was prescribed steroids to boost her. And we find that she had kind of her sugar level went up. They were given, she was given metformin liquid. And I was just wondering, how long has she to carry on with this? Because the steroids have stopped now, about a month ago. But did she continue with this metformin?
And what age is she? Do you mind me asking roughly what age?
She's 39.
All right. Okay. So yeah, in general, what you're describing there is high blood sugars induced by steroids. Of course, it could be that someone has risk for diabetes anyway, and maybe some of us are going to develop diabetes anyway. So that would be the other possibility. But if it is purely induced by the steroids, it should go away within a few short weeks of the steroids stopping. So if it continues longer than that, then perhaps there could be an underlying glucose intolerance, which might require further investigation.
Her level is 5.6 normally.
Was your daughter on any other medication, Mervyn?
She is other, yeah.
Yeah. Because I recently had a blood test, and they said they asked me if I was diabetic, and I'm not. But evidently, one of the tablets I'm on for my kidney also raises your blood sugar. So you need to watch out for that as well. So
and of course, if you've got one autoimmune disease, then it is likely that you might get another. So diabetes is autoimmune.
Well, type 1 diabetes is autoimmune and is less common than the type 2 diabetes. So it wouldn't be a common association with diabetes, but it would be slightly more than random. But some other autoimmune diseases like thyroid disease if someone has unexplained symptoms, it's very well worth. I think anyone with ITP probably should get their thyroid function done maybe once a year or so, because thyroid disease, particularly hypothyroidism, which is autoimmune as well, has a strong association with ITP, relatively strong. But diabetes, the association is relatively low symptom, because type 1 diabetes is uncommon. And when we think of diabetes, the majority of cases are type 2 diabetes, which is not autoimmune.
Yeah, because he's also a kidney transplant patient.
All right. Well, you're right. Well, that's then she is on other medication, which could also be a factor.
Dapagliflozin,
may have had
dapagliflozin,
cyclosporin, again, I check with her nephrologist. She should check with her nephrologist. There could be more than one drug contributing, or there could be other underlying conditions contributing, you know. So that's a more complex situation. But if someone has if someone has completely normal blood sugars and no other conditions, and they take steroids for an acute condition for a short period, and the blood sugars go up, it should go back to normal within a few short weeks of stopping it. But where there's other factors that persist, then that might not be the case at all.
No, her level is low now. It's very low, 5.6.
Okay, everyone. I think we've gone over time now, but thank you very much.
Thank you.
I hope you've all found it interesting. And Karen, don't forget, email me afterwards and I'll put you in contact with Rhonda.
Merv, what is your email address? Because I wanted to ask you about some fundraising stuff.
Yeah. If you just email info@itpsupport.org.uk.
ITPsupport.org.uk. Yeah, got it.
We'll pick that up. Yeah.
Okay, thank you.
Okay.
Yeah.
Thanks so much, Gerard. Thanks, everyone. You take care.
Nice to meet everybody.
Love to see you all.
Thank you.
See you all again.
Bye, everybody.
Bye-bye.
Good luck, Karen. Good luck, Karen.
Yes,
Have
thank you.
faith. It'll be all right.